For those of you joining us online, welcome. For those of us interested, a big welcome. And for the new faces, we're really happy that you have joined us here at Biodesign today. My name is Cyan. If you haven't met me, I'm the Health Equity Lead here at Biodesign. And this is part of an ongoing series, Health Equity and Innovation Talks, where every month we have an opportunity to hear on different topics around innovation and equity from innovators, from academics, from our fellows, to really stimulate conversation and catalyze community around this topic. So thank you to our partners for making this possible, the Bay Area Global Health Alliance, the Center for Innovation and Global Health, and the Stanford Global Health Club. You will hear more about them at the end of the event today. And then just before we begin, some housekeeping. Please do help yourself to snacks throughout the presentation. It's there for you to enjoy. Please just make sure your phone's on silent. Those of you who are new to our building, the bathrooms are straight through this door. You go through this room is through that door. And to those of you online, we will also be taking questions from you towards the end of the session. So do feel free to post your questions in the Q&A and we will get to them at the Q&A portion. So this happens once a year that we get our fellows to do the brown bag, which is really exciting because there's actually a lot of wonderful health equity work happening in our community. And we think it's really important to highlight and amplify the voices, not just of those externally, but also those in our community. And just to give a moment to share the incredible work being done and to learn from you. So today is our fellows discussion, and I'm really happy to introduce two of our fellows. So Charlene is a Stanford Biodesign Policy Fellow on upstream structural interventions to improve marginalized people's living and working conditions to promote health equity. Her doctorate invited direct care workers to co-design policy and technology to support their needs and preferences regarding portable work benefits. She has conducted patient-centered community-engaged research with thyroid cancer patients and Latina breast cancer survivors and their caregivers. She researched the intersection of health services and culture, for example, examining how Chinese American and non-Hispanic white breast cancer patients and oncologists communicate about patients' emotions, and how Native Hawaiian and other Pacific Islanders youth experiencing homelessness would integrate their ancestral cultures in sexual and reproductive health. Our second fellow is Ivana. She's a Biodesign Innovation Fellow. For those of you joining us online, we have Innovation Fellows and Policy Fellows, if the distinction isn't clear. And before coming to Biodesign, she was the CEO and co-founder of Adapt. It's a medical device startup designing a solution for people living with ostomy bags. Ivana studied biomedical engineering at the University of Barcelona, followed by a master's degree in healthcare design from Imperial College London and the Royal College of Art, and another master's in industrial design engineering from Elisava University in Barcelona. She has 7 years experience in the healthcare sector between Barcelona, Paris, and London and Boston. And in her free time, she participates in healthcare hackathons and travels around the world. She's fluent in Spanish, French, Catalan, English, and a bit of Mandarin. So we're really happy to have you both here today. And the overarching theme is talking around innovation and allyship. And why we think this is so important is that innovation doesn't happen in a vacuum. Even if the innovation team is small, we're innovating with communities, and the effects of innovations are always felt. And we feel this is really important to highlight that it's a whole community effort. And we really want to talk about the justice component and the allyship component. Because here at Biodesign, we're a global community, we also know that talking about allyship is important because we never ever want to innovate for other people. We always want to innovate for. So what does it look like to be responsible global health innovators that are creating access and equity, doing so in a really thoughtful way? So to kick us off, I'm going to invite Ivana to come share, and then Charlene will share, and we're going to leave a lot of time for Q&A. So please take questions while they're sharing. Ivana, thank you.
Right, thank you so much, Cyan. Okay, I'm really excited to be here today to explain a little bit about this project that I worked on innovation and in ostomy bags within the US and Caribbean. So before I start, I just want to say that this project actually started some years ago when I met someone with an ostomy bag that was having a leak. And back then, I remember thinking, like, okay, what is actually an ostomy bag? And being from a healthcare background, why have I never heard of this before? So let me tell you a little bit what I learned. So an ostomy, for those of you that don't know, is this surgery that is performed when there's a colon cancer or Crohn's disease, for instance, that consists on cutting the intestine in the affected zone. And what they do is they cut it and then they divert it to the abdominal wall, forming what you see here in red, which is known as a stoma. So it's a little bit of the intestine. So all the stools are going to be going out from this stoma. And because of this, people need to use what is known as an ostomy bag to collect those. So we're talking about 15 million people worldwide living with an ostomy. This is how ostomy bags look like. So what you're seeing is basically there's the wafer that is the one that is connected here to the skin and to the stoma. And then there's the pouch on it. They're going to be emptying it several times per day. And then they're going to be throwing it and dispersing it. So the pouch, they might dispose it every day. And then the wafer, they might keep it longer, like 2, 3, 4 days, and then throw it potentially. Those are the two pieces. There's also the one piece ostomy bags, which are these ones, where basically it's all together. And it's a little bit the same. They're gonna remove the adhesive, put it here, empty it, and then dispose it. So the truth is that the ostomy bags haven't seen a lot of innovation since they were invented. And even if it looks invisible from the outside because of the antithesis on their clothes, the truth is that there are many people around us that live with ostomy bags. So let me tell you about some people that you might recognize that have had an ostomy. So this is Napoleon Bonaparte. There's a big belief that he lived with an ostomy from a gunshot. Some others are former President Eisenhower or Matthew Perry, the actor, that lived with it for a few months because of Crohn's disease. For the former president, and for Matthew Perry, it was because of opioid use disorder. But the thing here is that basically it's a very taboo topic, but lots of people around us live with it. It might be temporary, it might be permanent, depending on the person. So we started by doing this survey where we got more than 200 responses to understand a little bit what were the burdens of living with an ostomy bag. So we realized that from the survey, 50% of users experience leaks every week or every month. And when we're talking about leaks, it's not just, okay, I have a leak, I need to go home and get changed. We're talking about skin irritation, about pain, about sometimes even going back to the surgery room because of that. And why is this happening? This is because current bags are adapted and designed for what is known a little bit as the ideal stoma. This rounded, a bit like what the surgeon has when they do the surgery as a guide. But the truth is that most stomas actually don't look like this. The intestine after the surgery reacts and retracts the stoma very often. Sometimes it protrudes it. And depending on the type of surgery, they might need to do a loop ileostomy. So the truth is that every shape is different from person to person. And what they do right now to customize to the shape is that they need to every day to take the bag and cut it themselves manually to really simulate this shape. And the truth is that even when done perfectly, which is not often the case, it's still very stiff. It can create cuts to the stoma as well. And at the end, you're putting something that is completely flat into something that is curved and that is going to be changing during the day. So it just doesn't work. So at this point, we were like, okay, how can we solve this? So we came up with this idea of saying, why don't we actually just customize them, right? So we did, you can see me here doing a scan with the smartphone of the anatomy of the user. From there, we were customizing the wafer, so the plate, completely to the anatomy. They had any scars. And then we were 3D printing it in biocompatible silicone, where we would add a gel that works as an adhesive, and then people could clip whatever pouch they prefer to use it with this. So the great thing about the silicone is that not only it's super flexible, but also it's reusable. So you can clean it with soap and water, you can boil it, you can sterilize it a little bit like menstrual cups. But the thing that we didn't take into account is that actually 3D printing has been here for years, but not 3D printing in biocompatible silicon. And this is actually very expensive to manufacture. So we reached this point where it looked like this was working. We were doing experiments, but then realized like this is actually really expensive and it's only one part. They still need to buy the pouch. So here is where last year I decided to audit a class on frugal sciences from Professor Manu Prakash here in the bioengineering department to learn a little bit about, okay, there must be a way to do something that actually performs better than existing solutions with a lower cost. So when we say frugal, and this is really important, frugal is not cheap. So when we think cheap, it means low quality, low cost, and lower performance. Frugal is not this. Frugal is, it works as the standard product or even better at a lower cost. And this is what I wanted to learn how to do it and what was our main goal. So the team that we came together to work on this is Ben, that is here in the room with a postdoc in the bioengineering with Professor Manu Prakash, Mario, who is a master's student at this school, and then we also had Bhav, who was in India, which was really key for this project, and then Professor Manu Prakash, who is also from India, which was, of course, very key. So when we came together, we knew there was a problem on people getting access to ostomy bags worldwide. So these pictures that you see are from the Philippines, but this happens in many places around the world, where because ostomy bags are very expensive, people start creating their own customized solutions. So in India, we had visited it before. We knew ostomy bags were $3 and it's just not accessible. So most of the population in India pays out of pocket for everything and doesn't have health insurance. So we started interviewing ostomy influencers in India and people from the Ostomy Bag Association. So I wanted to hear it from them.
In India, I would say the cost problem. Like in India, we say the basic need is food, clothing, shelter. But now it is also a basic need for them, a stoma bag. So anyhow, they have to buy it. And some people, because they cannot afford, they normally keep ostomy bag for almost 10 days, 12 days. And because of that, their skin get degraded or they start having skin problem.
The cost is too high. Surgery is just a part, but post, because it is a lifetime maintenance for you. Once you have this bag, it's lifetime. I know a person who just wraps some, cloth around their bag and they wash it because they can't afford a bag.
So it's a little bit this idea that surgeries of ostomies are starting to become available in places where they didn't used to be available, and that's great. But people are thinking about the surgery and not the post-surgery. And the truth is that if you live with an ostomy, you need an ostomy bag, because we're talking about acid gastric going out of the stomach. It's going to burn the skin. It's going to be painful. It's going to cause irritation. If there's irritation, the next bag is not going to go in, and it can be a real problem. Another thing that we learned is that everywhere in the world, but in India, for instance, it's really stigmatized, right? So here, this person was telling us, I don't go to the temple anymore because I feel like I shouldn't be there. And it's all of this aspect around it that it's still very taboo. There's a lot of young people with this, older people, babies, women, men, and we need to talk more about this. So another thing is that in India, so in the US, in Europe, when you live with an ostomy, it's considered a disability in the sense that you get a lot of help and resources around this. In India, it's not considered, which means there's less laws around it as well. And that is also, it's also challenging. So what we did is that we applied for a grant with Mario, Ben, we got it, and then we decided to really go there and learn from the ecosystem of ostomy in India. So we traveled to India and we shadowed different hospitals for a month. So we went to Anantapur in rural India, it's around 3 hours from Bangalore, and then to big cities in Mumbai and Delhi. And so for those of you that haven't been to rural India, the hospitals can get really crowded. So we did the shadowing where they see patients with ostomies, and here are some of the things that we learned. So first thing is that in rural India, there are a lot of cases of ostomies with fever or intestinal perforations. We also learned that patients actually come to the clinic every 2 weeks to do the change of the bag. They don't do the change themselves at home because very often they lack from spaces to do this type of things in a hygienic way. So they always go there. Ostomy bags are not designed for saris. So saris are these beautiful dresses that they wear, especially in rural India, that are more traditional and beautiful. And these bags are designed to be put vertically, so because of gravity, and you empty it this way. So when they ask how they want the bag to be put, they always want it horizontally, just because it's more accessible from the dress, and it's just not inclusive, right, for this type of dressing. And then it's gonna cause more leaks because of that. And then the other thing that we learned is that they really reuse very often the bags. So these bags are meant to be disposed, and they clean them with soap and water because they reuse the adhesive that stopped working. So they very often start wrapping around the bags a lot. They also have this type of design for colostomies, which is very interesting because it's reusable. This part, it's like a sponge. And they only use it for when the stools are for colostomies that are more solid. And otherwise it creates a lot of leaks, and they put these plastic bags on top that they throw and put a new one, but they still have many problems with leaks. In the Ostomy Bag Association in Mumbai, we learned that because there was so much of a pain point of cost, they actually decided a few years ago to create their own brand within the Ostomy Bag Association, which is pretty interesting. And they do have a low-cost bag that costs around 50 cents. The problem with it is it's actually reusable, but it creates a lot of leaks and it's considered more low quality. And another interesting thing is that there was really they were telling us people that can't afford the bag, they're gonna go to the clinic, but people that can afford them are still gonna prefer to pay someone to do the bag change for them. And there's not this, they don't wanna change it themselves at home. So that was pretty interesting because there's always this touch point with the healthcare professionals, and they keep going them. Then there's a big gap for pediatrics, for options for children. They don't have any affordable options. And the truth is that they still very often use betel leaves for children. And because they have antimicrobial properties, they use this, but the truth is that then the parents need to be there all the time, really monitoring and taking care of this, and there's a lot of leaks problems. So when we came back from that experience, it was clear to us that we couldn't do this without all the community, that when we went there, we didn't go there because it's an easy problem. We went there because it's harder and it's challenging, and we really wanted to learn from them. They are the experts, the ones especially in the Ostomy Bag Association, and work with them to come up with solutions to this. So we are now working on that. And another important thing is that Frugal, for us, we don't see it as we're designing for India and only for India. Frugal is good for everyone. So the way we see it is really that what we're gonna do there with the community there, we also need to implement it here. And there's a big problem. We've seen people in the US also reusing bags. We've seen people going to the emergency room because the insurance doesn't cover enough bags for a month, and it's their only way to get more bags for free. And we want to work on this. So when we came back, we knew that we needed like a simulator to test our ideas. We had seen this at the Exploratorium, was the way they tested shoes back in the days, and we were like, we need to build this to test everything. So Ben, who is an expert on all type of experiments, started building different setup of basically we simulate the bellies gripping in different ways, different bellies, different movements. And from them, we've been doing lots of experiments in the way bags are actually failing. So we went back to the ground really and understanding, okay, what you're seeing here is the little blisters that are created from point A to point B. And when you get that connection is when you're getting the leak. So really to understand how to break this pattern and avoid the leak in cheap ways, but in ways that work better than existing solutions. And we've been working on it. Ben is the one working on this right now in the lab. Mario is also gonna do his dissertation of the master on this project probably. And this project is still ongoing. Vipath is also actively working with us, and I just wanted to say a special thanks to all these people that were key for us. So Mohit connected us to lots of people, and the Rural Development Trust, the Student Bank Association, and we're still in contact with all of them. So thank you so much.
Thank you so much, Ivana. What I really enjoyed about that presentation, the work you've done is that you really highlight Frugal isn't about substandard. And I think there is a huge semantic misconception of that, but really affording people quality healthcare and a lower cost for useful ownership of that. But for here, for us in the United States, I think articulating what are costs that are unsustainable. That's how we learn from innovation around the world that are doing this so that everyone can have benefit. So thank you so much. We will have questions for Ivana at the end. Now I'm going to welcome Charlene. Yeah. This one. Okay. Yes. Oh, just one.
Thank you everyone for being here today. So I'm going to go over one part of my doctoral dissertation, and it was co-designing policies with direct care workers for better work conditions and benefits. I'm going to go over the why behind the project and very briefly the how. So first of all, have any of you ever been hospitalized or visited a loved one at the hospital and you can so was there someone there to help the patient, take care of themselves, help them go to the bathroom, make sure they had something to eat? So that person there was a direct care worker. And then so direct care workers, they help patients and people who are elderly or people with disabilities with activities of daily living. And they often work in their clients' homes or in healthcare settings, including hospitals and nursing homes. And they have a lot of different names and there's some variation in terms of their roles. There's home health aides, personal care aides, but ultimately, I think what they all have in common is they do the very important work of keeping people alive. So if you think back to the direct care workers, maybe you've seen in hospitals, you can think about what did they look like? In the United States, they were probably, they're female or a person of color or an immigrant. So I want to ask, what percentage of the United States would you say is female?
50.
Yeah. Yes. All right. So what percentage of the direct care workforce do you think is female?
75.
Yeah, 87. Okay. And then, so what percentage of the United States would you consider people of color? That is anyone who doesn't identify as only white when it comes to race or ethnicity. And I understand it's not the best term, but what percentage?
40-30.
All right, 42.
Whoa. I guessed.
Yeah.
Now, how about the direct care workforce?
85.
78.
90.
All right, 60. Okay. And then what population of the US would you say is immigrant?
25.
5. 48.
18.
14.
That's
And then how about the direct care workforce?
40-30.
60.
Yeah, pretty close to double. So you can tell that there's overrepresentation in the direct care workforce of women, people of color, and immigrants. And I want to say that's not an accident. It's actually part of a long-standing pattern we have in the United States. of having women of color and immigrant women do direct care work, the task of keeping people alive, for very little or no compensation. And a lot of this pattern originates with colonialism, slavery, patriarchy, and the National Domestic Workers Alliance has done an amazing job of tracking these trends. And I'll give you the link to this later. But what they also do, another excellent job of is showing that at every era of exploitation, there has been resistance the whole time. So I want to just remind us all that we need direct care workers. The way the United States is aging, there simply is just not enough family caregivers to take care of the population over 80. And then, but as things currently stand, and I'll explore why in a little bit, there are actually more direct people leaving the direct care workforce and entering the direct care workforce. And ultimately turnover or absence from work due to illness and injury, ultimately it hurts patients also because it disrupts the continuity of care. So now I'm going to go over why did I decide to focus on policies for better work conditions and benefits. So this here chart demonstrates that direct care workers compared to the general US worker, they've divided them up into the 3 different categories: home health aides, personal care aides, nursing assistants. You can see all of these direct care workers have far more injuries and typically sprains, strains, or tears, soreness or pain compared to the average worker. And you can see it's particularly high among nursing assistants who work in healthcare settings. And that's partly because they're dealing with 20 patients a day instead of 1 patient. So I would consider work conditions to be a social determinant of health because you can see just the nature of their work, creates pain. And then another reason I wanted to address benefits is you can see that with direct care workers, they have less access to any health insurance coverage, health insurance through employers or unions, and they're also not included in retirement or pension plans compared to like an average general US worker. And I think that's a bit of a pity because if you think about it, like direct care workers are enabling our health and they're enabling people to retire well, but we've not set things up so that they can be healthy and so that they can retire well. So I do consider work benefits and work conditions to be a social determinant of health. And this chart kind of explains strategies and tactics to address social determinants of health. I would say a lot of us are familiar with like downstream efforts, which is providing clinical care, medical interventions. And I think we're doing more as a society in terms of midstream. That's including, for instance, we've heard a lot of examples that including patient screening questions, understanding their housing or access to food, and then addressing those social determinants of health. But the part that I'm really, really interested in personally is upstream social, like how can we address upstream these social determinants of health? How can we prevent these disparities from occurring in the first place? And so that involves laws, policies, and regulations that create community conditions to support health for all people. And another reason I think it's very, very important to address policies when it comes to direct care workers is that historically, we have excluded direct care workers, the ones that work in home settings, from many labor protections that other workers get to take for granted. So you see here, I've listed the different acts that they've been direct care workers who work in home settings. So domestic workers more generally have been excluded from. So they've been excluded from all of these policies. You have the duration of the exclusion, briefly what these acts do. And then so historically, they've been excluded from the Social Security Act, Fair Labor Standards Act, the National Labor Relations Act, Title VII of the Civil Rights Act, and they're have been excluded from the Occupational Safety and Health Act. More recently, they have been included in the Social Security Act in 1950. However, many employers will commit misclassification fraud, where they will list direct care workers, home health aides as independent contractors when they're really employees. And that is a way where they don't have to pay into the Social Security benefits that the workers deserve. And in 2013, Obama, through the home care rule, included home care workers in the Fair Labor Standards Act, but there are still some exemptions. And they're still not, the ones who work in home settings are broadly not included in the 3 other acts. So why did I want to focus on a co-design approach? So there is this one documentary series, Natural Causes, and it focuses on social inequality and how that creates health disparities. And Michael Marmot is he's included in the documentary series, and this is a quote from him. So people who are disempowered, people who don't have autonomy, people who have little control over their lives are at increased risk of heart disease, increased risk of mental illness. So autonomy, control, empowerment turn out to be crucial influence on health and disease. So I wanted to find a way to give people more autonomy and control over their lives. And then so I landed on co-design. And basically, I would just summarize it as involving the end user in the design process. When it comes to a policy, I consider the end user to be the population most affected by a policy. And I do think that people most affected by a policy ought to have some type of say in such a policy. And co-design actually has a history of giving workers decision-making power. It emerged in Scandinavia in the 1970s and 1980s. It was known as cooperative design, and it was a way for workers to have a say in designing these computer systems that they would have to use. And so this chart here kind of delineates the differences between designing at, designing for, designing with, and designing by. And co-design falls under the design with category. It's also known as participatory design because Americans decided that using the word cooperative was too communalistic. And it's ultimately about what matters to people with lived experiences and decision makers. So now I'm going to briefly go into the how behind the project. So overall, this project was greatly influenced by this resource guide for policymakers about designing portable benefits. And briefly, portable benefits are benefits not attached to your place of employment. Similar to Social Security, they can be taken from place to place. And the idea is because so many direct care workers, they work for clients in home settings that perhaps this is an option for them. And then so a lot of the materials I share have been influenced by this resource guide. And then so briefly, the overall process was an in-depth interviews and focus groups, and then a generating ideas session with participants, revising ideas session, and a member checking session. And I'm only going to go into detail about the generating ideas session and the revising ideas session, but I'm happy to answer questions about the other parts of the process. So the generating ideas session, so it involved a brainstorming session, which I'm sure many in this room are quite familiar with. So here are how might we statements. So it's how might we design portable benefits so that more direct care workers have access to benefits, can be easily accessed by direct care workers, and that improve direct care workers' lives. So these might be too many how might we statements, but these are influenced by what came across in the interviews. And then so there's sticky notes, just putting ideas out. And then if people were ever stuck, based on the resource guide I showed, I created these cards that gave options that exist like around the world or in other states. So that was like a way to spark ideas. And after that, I gave them each kind of this idea shopping cart. So it's basically think of all the sticky notes as you're in the grocery store and you have all of these ingredients at the ready. What are you going to put in your shopping cart and put that in your concept? So that's the idea shopping cart. And then I gave them all a concept card. So there is, I gave them a blank here. And so these are questions that you need to think about when you're designing your own portable benefits concept according to the resource guide. And then I also gave them like a pre-populated version with suggestions from the resource guide and then also from their interviews. So that was the generating ideas session. And then so after that, after the session, I basically typed up all of their concepts and then I had them in the revising ideas session. I had them read and revise their own concepts and then read concepts by other participants and then revise their own. And I had them each in groups select one of 3 personas. And then so these personas are based on the interviews. And then each persona you'll see it lists like their struggles or their dreams for each type of direct care worker. And then I had them do a storyboarding exercise where they went through how does a problem from the direct care worker and then how does a persona experience work with the concept that the participants have developed and how does it solve? So these are my acknowledgements, all the people who helped me along the way and the funders, and then some resources of interest. And then me and Ivana had like a chat about like what allyship means to us. Can we decided like a part of it is like having a good attitude, you know, not trying to be a hero, but instead a responsible citizen of the world, listening well, respecting the expertise of the end users, involving the end users and the importance of the users. Then just go to the other side. And then, yeah.
Sharing that, I think as Biodesign has wrapped up our policy efforts, it's been so helpful for all of us to understand the crucial role policy plays in the work being done in healthcare. And it's beautiful to see innovation and policy starting to teach each other in a way that is. So thank you both for sharing. I think it was a really complimentary session. We're going to have some time for questions now. So we're going to try and mix it up between those online, those in person. If you have a question, please just raise your hand and say your name and a little bit about where you're from in terms of organizational affiliation. And Anja will be moderating the online questions for us. Anja, just let us know if we have online questions. So we can start with in person. Does anyone want to start off with a question? Yeah.
Hi, I'm Anastasia, second year fellow with Foreign Nurse Resilience. Thank you so much, both of you. That was super, super interesting. I'll start with Charlene. I was wondering, after you gathered all those insights and concepts, what is then the processing to transform them from ideas to policies? What is the next step?
Yeah, so the next step for me, I have a few manuscripts. So the next step is to actually just turn it into policy recommendations. So I have like a manuscript in development, but it's been on pause since I've been here. But the idea is I'm going to try to like include information about, you know, examples on the state or the federal level or in other countries, and then just make it a resource for policymakers to like, here's what people want and here's how other people have done it. So that's the goal, is just to get it out there in the written form.
Thank you. Yeah. Another question for Charlene. Oh, hi, I'm Shereen. I'm in the Biodesign Fellowship, Innovation Fellowship. Thank you both. Awesome talks. Did you find anything surprising when you were talking to these dark care workers, and anything you didn't expect to hear from them?
Yeah, and I think I've mentioned this before, but I think the interesting thing that I learned was that even among like nursing assistants who do have employer-sponsored health insurance, they actually cannot use it because they're paid so poorly that they end up choosing a high deductible plan to keep the most money they can in their paycheck. But then they know they'll never make the deductible. So then they just end up not using the health insurance because they just can't afford it, even though it's employee sponsored, but because many workplaces give the same rate to all employees. So in a way, they're subsidizing their coworkers are making more money.
Sorry, Dan, what's your question just for Charlene?
Yeah, but
Yeah, so I mean, a lot of things I think surprised us when we were in India. One of the things that surprised me also is that they already use a lot of things that are in a reusable way, and there's a lot to learn about this as well. And yes, that's one.
Okay, do you want to read that?
Yes, an online question for Charlene. Have you found any ways to be able to account for potential cost considerations of implementing/comparing policy solutions that might have come up in the brainstorm?
Yeah, actually, the participants were really great. They were really thoughtful about the cost considerations. So in the manuscript, there's like a lot of different options, and there's like a part where it's about like different financing options. They were very careful not to do anything that was not too like revolutionary. They're like, we don't want to look too communist or no one will take it. His words from like one participant. But they talked about maybe like, you know, in terms, instead of everyone paying the same premiums, health insurance, it could be like a sliding scale based on income levels or a percentage. So that was like one idea they had. And then, so that was just one idea. And then they had some other ideas too. But yeah.
I have a question for Ivana. It was very nice. Oh, yes, sorry, I forgot. Marta at Biodesign. So yeah, it was curious to see like how in both ecosystems, even if they are really different, like
patients are like taking the lead in like doing like their own like personalized solutions. So yeah, I was wondering like, actually I forgot your question. I was wondering, in terms of like the product validation, I know you guys made like a lot of interviews in the US. And yeah, I was wondering like what things do you feel are common and your solution could help bridge the gap between the ecosystem?
I think there's a lot in common at the end. Um, it's something that is very stigmatized everywhere. It's something that it's leaking on all the solutions that exist out there. So they all share the same pain point in that sense. So whatever we design that a little bit touches all these things from like the access and cost standpoint to the leakage to really also like raising awareness and talking about this, it's something that is really important and we believe is exactly the same in both places.
And now I remembered like part of the question was in terms of business models, like have you considered like what are your thoughts on the business model?
Yes, and it's something that we are now exploring. So we've thought about very different options from really having something that is just accessible to everyone and we're just selling it it's a lower cost and it just because the way of manufacturing it and the insights in the design itself, it just makes it more affordable and it's actually better. And we strongly believe there are ways of coming up with those type of solutions. And we've also considered other ways in the sense of it seems there's some businesses that sometimes they have like ways where you're gonna have one product that is gonna help you finance the other one. So we're also considering another type of business model and it's something we're still learning and exploring.
Thanks for this.
We have two more from online, both for you, and I will kind of get two questions in one package and you can answer them while you're speaking. The first one is, did you learn anything from the process that you would do differently next time if you had to do it all over again? And the second question is, how do you measure the impact of your product or policy and what would success look like?
In terms of doing anything different, I think there was just a lot at the beginning in terms of administratively that I just it was just like getting access to the funds. So it's nothing to do with interacting with the patients, but just a lot of like logistical stuff where if I had just known who to contact, I probably would have like moved a little faster. That's that.
What would success look like?
Yeah, so a success to me would look like just policies passed that support this population. There is a National Domestic Worker Bill of Rights that's been introduced to Congress, and then it closes a lot of those loopholes. And then also like more recently, as I was doing this project, Maryland passed 2 laws related to direct care workers that are where their labor is paid through Medicare, but that wasn't because of my project. That was just because of other people along the way also doing important work. So just like more laws and protections for this population.
So for me, I think one thing that we talked about in the team and that keeps coming back is we spent there 1 month, and once you're there, it always feels short. Like if we had the opportunity, I would have stayed longer, and it's something that we really want to go back. And when you do this type of projects, you really need to be there, and we have a lot of people there working with us, and that's the key. But also spending more time there and creating more of those relationships. And then in terms of success for us, there's 2 things, no? Like, there's one that even like talking about these things for us, it's already a big part in the sense that we're raising awareness, we're making sure that these topics should be talked more about and people are comfortable addressing them. And then there's the other part that, of course, success for us means getting something that is accessible to people that don't have access to ostomy bags right now.
It's a good question for Charlene. I know you were talking about, Sammy, also from Biodesign. That you were talking about how you had like kind of independent work and then they got to see each other's work. did you find that that changed opinions to be more disparate, or did people come to like common themes? Like, how was
Yeah,
that?
oh, that's a
experience?
great question. Yeah, I do think when they did to see other people's work, there were some things for like, "Ooh, I really like that idea, let me put that in." So then like when I was doing the analysis, there were some ideas that popped up more because it just resonated with a lot of them.
There's a question at the back there. Please just maybe just stand a bit forward for those online, can the microphone can pick you up. Thank you.
Hi, I'm Fernando. I analyze a lot of data, but I was just wondering, because I'm also in an area where I help to create jobs for many people, what are some things what are the next steps you ideally hope to like move forward from here?
Me or listen to
Some action item.
some action items, like personally or like with the project?
Oh,
Okay. Personally, like I came here to kind of learn a bit more about the policy making process. I just want to, do those things also after learning about them. And then in terms of like the project, need to think about that some more. I think definitely it would have to be something working with direct care workers again. There were, in addition to just the stuff we had talked about, they also brought up, in addition to like laws that protect them, they also brought up issues with like enforcement, because there are some laws, like there are some policies in terms of like healthcare settings, in terms of like what's an appropriate patient to worker ratio. And, for instance, I also brought up the misclassification issue. So there's actually, even though there are laws protecting them, there's actually a huge problem with enforcement of the laws. And this was another thing that surprised me, is that a lot of the participants, they would be happy if the places they worked for were closed down. They weren't worried about losing a job. They would be happy if they closed down because they were violating the law. So I think maybe more work in how to enforce already existing laws that protect workers.
An online question, I think let's go there and then we'll come back.
A question for Ivana from an attendee online. I applaud your work. I come from India. This problem is close to my heart as my father had post-surgery until last year. I would like to ask, in your experience, what would be your key insight for introducing innovation in rural India amongst various stakeholders? Thank you, and sorry I couldn't join online in person today.
Thanks for asking. So I think one of the key parts for us on introducing it in rural India is this touch point that they keep having, that they go every 2 weeks to these healthcare facilities, which means that if we introduce it in a way with the surgeons, with the nurses, and we work with them, there's a way for them to access it. We also did a lot of, everywhere we were going, we were trying to visit pharmacies as well to see, do they have ostomy bags? Is it in this pharmacy? We go a bit further, do they have one? And we learned that very often there's no ostomy bags in the pharmacies, and when there are, there's like only one model and one option, and it's very costly. So it's, for us, it's really around the touch point, and from what we've seen during that month and our experience, that for us it's key that they go every 2 weeks, no, and it can be a way for them to access this type of solutions.
Krista Donaldson, Biodesign. First of all, congratulations, both. Your great work is so great to see. But a question for you is, how can community help you and support your work, especially with next steps? Like, are there specific things that you think the community might be able to help with, or give us some direction?
So I can start. For us, for instance, the Ostomy Bag Association of India, they already, like a few years ago, they identified there was this big pain point in India of lack of access and cost, and they started their own manufacturing site in India and grant. So that's a big part of it, that we discussed, that there's opportunity there to come together and do things, and they already know a lot of how these things work, and they are key point, they distribute ostomy bags all over India as well. So that's a big point for us. And then in the hospitals we visited in rural India as well, they know so much. They've been, there was this surgeon, Dr. Sudhir, that we shadowed once we were there, and he's been doing ostomies for like 30 years or even more. And he knows so much about the community patient and all the patients, that for us it's
Do you mean like the community I worked with, or like broader?
Broader,
This,
but it can be community or.
yeah. I
whatever speaks to you.
Yeah, I think what speaks to me is I would love like more acknowledgement just in culture and society about the importance of direct care workers or just the importance of like care work. But I think we live in a society where we undervalue it, we underpay it, so we don't appreciate it. And I think it's just like step one is just appreciating all the people in your lives who make your life easier and then doing your best to reciprocate and make their lives not as difficult also. So that's like step one. And you know, everyone can also, you know, if you're able to also call your representatives and talk about the National Domestic Worker Bill of Rights. And then I think just more conversations around caregiving, but then also more conversations and acknowledgement in our society and culture about the work that women of color and immigrant women have done historically and how it's underpaid, undercompensated. For acknowledgement of those patterns and doing our best to rectify them.
And we will share the link you mentioned to the site, which educates us about these issues when we release the recording on YouTube. So I think for all of us to learn more, we can also use that resource to provide it as well.
And can I ask one small thing? Yes, one thing that you might think of is also for us, for everyone, like I see very often, like for instance, in accessible restrooms, where you see someone going in and they look like they don't have any problems, any challenges, and you're like, oh, why is this person going to the restroom here? And there's a lot of judging around this, and is this remembering that not all disabilities are physical sometimes, and people need to access different places, and it's something that we're very judging even ourselves, or like when that person is sitting on a bus, why is she sitting and not this other person? And to always remember that there are things that are visible, but that's not true.
Yeah, I have a question online from an attendee who was interested in knowing from Charlene. How have you been able to connect with healthcare workers such as physicians who represent the different experience, for example, academic community, to be included in the design with part?
So is there a question about like how would I work with physicians?
How have you been working with them?
Like in the past?
Specifically for this project.
Okay.
You gathered your input.
Okay, well, this project I focused mostly just on the direct care workers themselves, the certified nursing assistants. I do acknowledge that it is important to also work with the people who work with them, like nurses and physicians, but I wanted to first center direct care workers. So in terms of like future tasks, that could be something I do later on, is work more with like the registered nurses and the LPNs and the physicians who, because that did also come up. It's just like in the workplace, they are not often acknowledged by their colleagues.
I have a question. So it's Yang, my name is Yang, and currently working on 2 startups at the same time at Stanford. And my question is, you know, when you build a technology or product, it's not about how much you love the product itself, it's how much you love the people you are serving, right? So that's why you hear their voice, you do everything you can to make them feel good about the experience, about the product, about themselves, right? And what I'm really curious, like what really inspired you guys to go out there to listen and to even challenge the classical method, like just do your own thing, right? And then just push it out. So what really like inspired you to like go out there and listen, really talking to them or even living with them, like in your case? So like what really inspires you?
Yes, I think for me, for instance, it's really, a lot of people ask me, like I've been with this project for so long, for many years, and I think it's really realizing that the problem is still there, it exists, and kind of falling in love with the problem in the sense that it's like so big that every year when I'm like, okay, am I gonna continue with this or not? Every time I keep saying like, okay, this is not solved. So there's this pushing that keeps me pushing of saying, okay, someone needs to solve this. And yes, if you really believe in the problem and you know it's true, I think it's.
I think for me, so some of this is personal. So my grandmother in Taiwan, she was a nursing assistant and she did this work. And our family just understood how much of a physical toll it took on her. And she passed away like far earlier than we would have liked her to. And then also I lived in Taiwan for a year, and they're getting really ready for the aging population. And almost a lot of people have like, you know, a direct care worker by their side. But I noticed like, they're all from like Southeast Asia, is this work exploitative? Is it creating these dynamics? And then what about the people that these workers care about back home? And then when I returned to the US, I was like, oh, it's like the same pattern. So it was just like, ultimately, if we're lucky enough, we're gonna age. And I think we just need to think about like how it's a thing I think that ultimately affects everyone if you intend to age, and how do you not exploit someone in order to get the care you need.
I think we're gonna have to leave it there, but before you two sit down, I wanted to present you with a small token of our appreciation. Thank you so much for sharing your wisdom. You're welcome to have a seat. I think today's session really highlighted a few key themes. Just what does it mean to solve really big needs when the obvious financial models may not work for you? What does it mean to work with invisible disability? To sometimes work with populations that are invisibilized by structures or policies or processes? And what does it mean to think of innovation more broadly than just a product? It's a policy, it's a process, it's a service. And how do we ensure that the work we're doing is thoughtful, it's collaborative, it really listens deeply to the needs of community instead of assumes that we know, and really values people's lived experiences and the non-conventional stakeholders. And I think through both of your sessions, you really spoke so much to themes that I don't think we speak often enough about in the innovation community. So thank you both. Just to wrap up the session and hopefully end on time, I want to just acknowledge that for those of you online, you can't see that, but we do actually have the other two team members from the ostomy team in the room. So I encourage you to speak with Ben and Mario if any of you want to hang around afterwards. And Ivana and Charlene will also be hanging around afterwards if you want to speak with them. So if you are joining online for the first time today or new in the room, we actually have all our previous talks recorded and you can find them on YouTube on this slide. We hope you enjoy them, share them, watch them. We just want to alert you, if you want to subscribe to the Bay Area Global Health Alliance, you can scan this QR code to connect. We, 2 weeks ago, had a really interesting event with the Alliance where we spoke about catalyzing private sector investment for global health challenges, the exact type of problems that we've chatted about today. And that recording is available. Please subscribe to their website. And before I speak about this, I also do want to say that we have our Global Health Club present here today and the Center of Innovation for Global Health. Many of you want to get more involved in global health. They have regular journal clubs and meetups. Please reach out to Hope or email one of us for those contact details. So excitingly, our next event is on the 25th of Feb at 1:30, and it's with Neha Agrawal from PATH. And as we think about solving really hard problems, we acknowledge we're going to have to think about different financial instruments and business models. And so Neha, together with PATH and the Bay Area Global Health Alliance, is pioneering outcomes-based financing as a tool for health equity, which is a different funding model. And she's going to share with us a case study of them using that for antimicrobial resistance. And then looking ahead on the 11th of March, we're going to be hearing from Jane Chen, who many of you may know as the CEO and founder of Embrace Global, a global health innovation. And Krista Donaldson is going to be interviewing her about lessons learned working in this notoriously difficult but really important space. And then on April 8th, we're going to be hearing from Sarah Olson, who is the CEO and founder of the SVT Group. And she's going to be speaking to one of the questions I've asked today. Why is impact assessment important and crucial to successful health technology innovation? We're providing real-life case studies of impact assessment of health venture funds and health innovation startups, and speaking about how we can learn more about this tool in real life and in practice. So I invite you to follow our channel and to sign up for those events. And then the Health Equity Program at Stanford is also growing. And if you or your organization are interested in partnering with us, please do reach out to me. My email is my name, cyanb@stanford.edu. And for those of you joining us online, it's the end of the session. Thank you so much. For those of you joining in person, we're going to grab a quick photo and have some snacks. And just to end us off, thank you to Anta, Deja, and Danny and the Biodesign team for our speakers today for making this happen. Thank you, everyone.